Moving on to the next session, I would like to welcome our organizing secretary, Dr. Bhushan Bhaware, to present on acute pancreatitis. It would be a case-based discussion. I would like to call upon Dr. Gaurav Padia, Dr. Saurabh Patle, Dr. Ravi Daswani, Dr. Manoj Vyavhare, Dr. Ashok Bhute, Dr. Madhuri Hole, and Dr. Ashwin Chinchkhede to chair the session.
It's very nice to see that Midas Hospital is really expanding from a single specialty to really a multi-speciality. We can see all medicine topic being discussed here. So let us back to our gastroenterology topic. So it will be a very poll-based discussion. So I request all the audience to just be attention. So let me start with this a case of 33-year-old male who presented with a severe epigastric pain since last 2 days with fever, nausea, and not past stool and vomiting since last 1 day. Patient also complaining of an decrease breathlessness and decrease in output since 1 day. Patient has no comorbidities, no similar history in the past. Patient has no jaundice, no GI bleed, no NSAIDs, no pedal edema, but patient has significant alcohol consumption, which he takes daily, due quarter of an whiskey, with the last intake was a night just before the pain, onset of pain. So on clinical examination, patient was having conscious, oriented, but little bit irritable. Patient was having tachycardia, hypoxia, febrile. On respiratory examination, there was a reduced air entry on the left side. Per abdomen was slightly distended with mild gardening and tenderness. The investigation which we did on day 3 when the patient came to us found to have an severe leukocytosis. There was a raised hematocrit. There was a renal failure. Bun was elevated. LFTs were nearly normal. Serum lipase was elevated more than 3 times the upper limit of normal. Procalcitonin level, what we did on the static was slightly elevated to 1.2. CRP elevated. Calcium triglyceride normal. X-ray suggestive of an left pleural effusion with mildly dilated bowel loops. We did a sonography suggestive of just a fatty liver, pancreas inflamed with thin rim of collection, no IHBRD, no gallstones, and the kidney size appears to be normal. So it's a very important in the first week. You all have seen the patient in the first week of acute pancreatitis. What are the pertinent issues? The first is like diagnosing the patient of acute pancreatitis correctly, because having overlapping features of sometimes intestinal obstruction, intestinal ischemia. The another question that is when to start feeding, whether to keep a patient NBM, enteral feeding, TPN, which IV fluid to start, at what rate, which analgesics to be used, what are the role of antibiotics, and when we should do a CT scan. These are the really pertinent issues. So first of all, I need the definition of acute pancreatitis as per the Atlanta classification. It comes a typical epigastric pain which is radiating to back. The serum lipase should be elevated to 3 times the upper limit of normal, and imaging features suggest to have an inflamed pancreas. I really has anything in the poll, if you can. Any one of the poll that yes, I can go, like how to diagnose pancreatitis. We need all of the 3, any 2 of the above, or any 1 of the above for diagnosing of an acute pancreatitis. Because many times sometimes we have seen patient just a single lipase elevated and will label pancreatitis. I think so most of the physicians are very, not there? Great. I think all of it are. It's any 2 of the above that we should be there for defining a patient of an acute pancreatitis. So it's not like only lipase elevated, is not like only USG findings suggestive of at least 3 out of 2 should be present for diagnosing a patient of an acute pancreatitis. So another one important point after that is why the disease is very important, and why I'm pertaining this, why first week is important is because of the mortality rate of an acute pancreatitis. As you can see, 80% of the patient we present at near about having a mild pancreatitis. So what's a mild pancreatitis is that patient has no organ failure and there is no peripancreatic necrosis documented. And most important is this, the mortality trends to be 0 to 1% is managed properly. But once it comes to a moderate pancreatitis, 20%, which comes to a moderate to severe pancreatitis patient having a persistent or a transient organ failure with a severe pancreatitis, the mortality tends down to be in a range of 13% if the patient have a non-infected collection and it turns down to more about 35% when it comes to an infected pancreatic necrosis. So that's a very important point of distinguishing a mild from severe pancreatitis in the very first week of the disease. So I really go for another poll question. So which is your preferred score to predict an acute pancreatitis on admission and at 48 hours? It's a very important question that distinguishes the patient at where the patient is going into the first week, how the patient 4 weeks would be. It will be a BSAP score, serum lipase, these are the Apache score, SIRS, or we should do a CT scan immediately on admission. I think, yes, people has voted for Apache, Ranson. Yeah, it's more about, BSAP score and Apache score has given us this thing. One of the important highlight of this slide is that serum lipase is not considered as a severity marker of an acute pancreatitis. It is a diagnostic marker. Many of the patient comes with a repeatedly day 1, day 2, day 3 patient are doing serum lipase to just make sure what decreasing or increasing trend will not to them. This is the latest ACG 2024 guideline just came in the month of May 2024, where they have given that not a single score or a single multivariate meta-analysis will tell us that whether the patient is going into acute pancreatitis. It is a conglomerate of physical factors, laboratory features, and the imaging features. But what I found in my practice is that BSAP score, if the BSAP score is composed of an BUN, impaired mental status, SIRS, age more than 60 years, and pleural effusion, if it is less than 2, we call it as a mild pancreatitis, and if you are more than 5 or 3 to 5, we call it as a severe pancreatitis, and the mortality as already I told you. So BSAP score is a very nice bedside score at admission. We can really categorize the patient is going into mild pancreatitis or a severe form of pancreatitis. So again, the question goes into poll, very important question. What is the base fluid to use for an initial fluid resuscitation in a patient with acute pancreatitis? Lot of literature in last 2 decades, whether aggressive ringer lactate, aggressive normal saline infusion, goal-directed ringer lactate or normal saline, or any of the fluid, crystalloid, or any of the above you want to do. Because this is, just we can start a poll immediately, that will save our time. Let us see what audience are voting for. I think so an aggressive, it's a very well, you can see people are, but goal directed ringer lactate was given this thing. So let us give to the evidence. What is evidence are going. Can you just change the slide, please? I think so it's not coming in animation. Yeah. So let us view. So there are 2 randomized control trials as shown in this slide. One came in 2011 from View et al. In Clinical Journal of Gastroenterology, where they have rightly given a 4 compare. They found that ringer lactate is best for reducing inflammatory response syndrome. But there was a second randomized control trial which also showed that ringer lactate was better than normal saline. But I can just pitfall what was the problem in the first RCT. The first RCT, given the infusion rate, you can see 10 to 15 ml per kg per hour. It was a very high fluid that they had given, and what they have come into the secondary outcome that mechanical ventilation rate, abdominal compartment syndrome, sepsis and mortality was higher in such patient as compared to the patient who was giving an under transfusion as compared to the first the transfusion which was given in the 10 to 15 ml. The second RTG which produced from De Maria from Dutch group in 2018, they have found that a patient which is assigned to rapid hemodilation, especially targeting hematocrit less than 35, they also found that the aggressive fluid resuscitation lead to an increased rate of sepsis in first 28 days. So this was the one thing was very clear from these 2 RCTs that ringer lactate was doing good with a less side effects of hyperchloromic acidosis, but the aggressive fluid resuscitation which was mentioned in the prior RCTs was not doing good for our patient. And this trial was conducted with a latest trial from same group of people called as a waterfall study, where they completely randomized patient into a 122 into aggressive group and 127 in the moderate group. In the aggressive group, they are given a 20 ml per kg bolus and then followed by 3 ml per kg bolus for 48 hours. And in model fluid resuscitation, they are given a 10 ml per kg bolus, only if hypovolemia perfused. And the ringer lactate was a fluid that were used in both the fluid. But one of the important point they have kept that fluid rate able to reduce or stop if the evidence of overload. And what they have found in the study that the percentage of patient going into moderate to severe pancreatitis patient going into fluid overload, and secondary outcomes in the form of infection, hospitalization was all were much higher in the aggressive group of resuscitation, and this trial has to be abandoned in between because the primary indication was that going into fluid overload was for patient going more complication in the aggressive group. So this has come to a point that among the patient of acute pancreatitis, aggressive fluid resuscitation did not lead to a lower risk of moderate to severe pancreatitis than a moderate fluid resuscitation. So what is the best clinical practice what we follow in our hospital is that we know that ringer lactate is the best fluid that we are starting in the first 48 hours. Rate of infusion, I mean, is 10 to 15 ml per kg, but with a very nice goal-directed approach. Monitor heart rate, monitor burn, monitor his hematocrit. Caution, not like everything, one size fits for all. Caution that elderly, cardiac, renal disease patient has to be taken, not like this is applied for all the patient. And patient which is not responding for the fluid overload in the first 24 to 48 hours, I really not recommend to give such an aggressive fluid for such patient. So this is the very best practical advice for current management of fluid. So now again I go into the poll. What is the most effective analgesics, or which is the most effective analgesic you people use for management of patient of pain in acute pancreatitis? It has really found that pain also stimulate and SIRS. If you not decrease the pain, the SIRS may prolong. So let us see. So yes. Very good. So majority people are using opioids for management of pain. I just want to hear only one RCT from India, from AIIMS New Delhi, where they have used a pentazocine, which is a very easily drug available, mostly gynec people are used, versus an diclofenac in 50 patients. And what they have found that the total dose of fentanyl nude, which is a rescue treatment for the patient who's on both the arm, was lesser in pentazocine as compared to diclofenac. Pain-free period was also lesser in pentazocine as compared to diclofenac. And what the author concludes that this pentazocine is a very cheap drug, is also significantly better than diclofenac for pain relief in acute pancreatitis. So what is the best practice advice? I already know. Use opioid as a first line of management. Tramadol is what we goes for management. But I have a caution regarding of tramadol. Sometimes can cause a biliary colic, and in the question of biliary pancreatitis, it may increase the tendency of having a biliary stasis or something. But yes, at present, avoid NSAIDs at whatever best you can. But sometimes rescue, we can give a ketorolac injection. We can give another. Fentanyl patch can be really used in the first couple of days of the patient having a severe pain as a rescue management. So it is the best practice advice for the patient. So again, for a poll question. When to start feeding in acute pancreatitis? This is a very, very important thing. Whether the traditionally nil per oral is important, we can continue immediate oral feeding, total parental nutrition, or we can start an enteral feeding. Because this sometimes has caused more keeping. Let us see the poll first and then proceed. Yes, very good, very nice. Yes, people are quite known here, like how this patient, how we should not. Nil per oral has been traditionally has found in various meta-analyses, randomized control trials, that nil per oral is not doing good for our patient. Oral feeding in early course of acute pancreatitis has found to have shorter hospital stay, decrease infection complication, and decrease morbidity and decrease mortality. No doubt in it. This is very, we are practicing from long time. And this is the latest trials in annals of surgery called as the PADDY trial, where 131 patient was randomized into immediate oral feeding. Forget about the enteral feeding. Immediate oral feeding versus an enteral feeding. And what the people has found that the length of hospitalization and the complication was lesser in the patient who's having an immediate oral feeding. But I do take for the case of the patient having a severe pain, nausea, vomiting, not able to take a oral food, I prefer to put a patient, I just make sure the patient should not be in ileus, should not be in obstruction, should not be in compartment syndrome. These three things should be taken in your mind before the patient starting on oral or enteral feeding. So yes, immediate oral feeding resulting in significantly shorter length of hospital and significantly cost saving. So what is the best practice advice? In moderate to severe pancreatitis, early oral or enteral feeding. Immediate feeding if no nausea and vomiting or pain. And enteral nutrition is far better than the parental nutrition. So nothing like the patient should keep NBM patient comes with us, sir, we are NBM from the last 7 to 10 days, is more dehydrated, that is not going to do any benefit for our patient. So another most important question, and it's very, very important question, is that whether the systemic antibiotic prophylaxis is effective in preventing the complication in acute pancreatitis. So it's very important that patient having a WBC count elevated 24,000, patient having a fever on day 1, okay, our tendency is to start an antibiotics. Let us say how many people are using antibiotics in the first phase or first week of pancreatitis. So yes, very fantastic. So I think so, very great people are here, we can do this. So yes, it has been shown that basically what is antibiotics in acute pancreatitis is always centered towards a pancreatic necrosis. So our concept is that if the patient having an acute pancreatitis, pancreatic necrosis, the necrosis get infected in the first week. No, not like that. It has been shown in various trials and also in the pathophysiology that infection sets in after 7 days of an acute pancreatitis. But given a precaution, we should always rule out urinary tract infection, bacteremia. It's not like a hardcore stringent protocol that one node should not start an antibiotic. But if we found any high suspicion of an infection in the form of procal elevated to significantly high level, or the patient is having a blood cultures positive on day 3, day 4, yes, that becomes important. So the most common antibiotic which has been used in various trials is a carbapenems, fluoroquinolones and metronidazole, which has found to be highest penetration rate into the pancreas as compared to the other antibiotics. But prophylactic antibiotics may do more harm than good and therefore is still not recommended. So what is the best practice advice? Guidelines, routine use of prophylactic antibiotics, not recommended. Antifungals, not recommended. But when infected necrosis is suspected, we can use an antibiotic which I already mentioned that has a highest penetration into the pancreatic necrosis. So another going to a poll, what is the timing? That's important. What is the timing? When we should do a CT scan or when we should advise CT scan for initial assessment of an acute pancreatitis? Many patient comes with us with a pancreatitis immediately on admission, within 24 hours, 48 hours, or we should wait for 72 hours and then we should prescribe a CT scan. Always a plain CT scan, contrast CT scan, pancreatic protocol CT scan. Let me see what's the poll. Fantastic. Good. Yes. It is required. It would required almost after 72 hours. So basically, CT scan is not going to change the line of management in first 24 to 48 hours unless you are suspecting some other etiology in the form of ischemia or obstruction. For acute pancreatitis, no. It is only for a diagnostic uncertainty. Confirmation of severity, yes, it is confirmation of severity, but in first 24-48 hours, not at all, will not change our line of management, or failure to respond to conservative treatment or in the setting of clinical deterioration, that always we will do, but not in the 24 to 48 hours. It is always after 72 hours. And why it is always CT always 72 hours? Yes, we have BSAP score, we have many other score that will predict the severity. CT scan will not add anything to our knowledge. It poses a contrast. A couple of times we have seen patient having a development of contrast-induced nephropathy than the patient having an acute pancreatitis. That makes our life much more difficult. Complete extent of pancreatic and peripancreatic necrosis only become obvious after 72 hours after the onset of acute pancreatitis. So that's a very important take-home message that first 24-48 hours, CT has not going to change our line of management unless you are suspecting some other etiology for abdominal pain. So yes, so just come back to our question, coming back to our case. So this is you say this patient was having a very moderately severe pancreatitis, renal failure, BSAPs was 3, admitted in our ICU. We started, the patient was having severe pain, we started an analgesic in the form of tramadol. We immediately put an nasojejunal tube, started ringer lactate or whatever. He came in 48 hours. I was very considerate not to give much more. We are targeting on 2 to 2.5 liter. ICU, started on analgesics and wait for a CT scan. So after initial resuscitation, after renal failure was reduced, we did a CT scan because patient was now going into a very high grade fever. What we found in the CT scan, a very bad necrosis, more than 90% pancreas has been burnt out. And you can see there is no enhancement of pancreas other than you can see a body on tail. It is like the pancreatic necrosis is extending not only into the lesser curvature, bilateral paracolic gutter. This is the during, we started conservative, we started antibiotics, we gave a procal is elevated to 3.2, we continue the patient, we given a, what we call as a broad spectrum antibiotics, fever was throwing on a high card, and this was a fever chart. You can see it's a dreadful fever chart, the patient was really, so after initial stabilization from our great ICU team here, but we are really stuck with a fever, which is coming into week 2nd and week 3rd. So I really have a poll on it, and also have a panel, Dr. Gaurav Padia. What is your intervention, gastroenterologist? What do you do at this stage? Patient is in 2nd to 3rd week. You see fever, blood cultures negative, broad spectrum antibiotics, enteral feeding. What do you think? What should I do? I should drain the collection or need to continue a management? Anyone? Poll? You can just start poll also. People should know what. Yeah. Yeah. Mike, yeah. We can listen, Gaurav. Yeah.
So, patient is in second and he is throwing fever, and obviously your antibiotics you're already given, but they are not working. So definitely we are dealing with the infected pancreatic necrosis, the clinical scenario which suggests. And in this scenario, either we are using the right antibiotics or not, firstly. Secondly, that the resistant infection must be there. So in this scenario, we can try to take a sample.
Okay.
If we find it's a very diffuse collection which we cannot drain, there are studies which have shown that you can do early interventions in the form of drainage in 3rd week or 2nd week when you feel the clinical management is not improving, and we can try to drain the collection also.
Absolutely. There are a lot of things, lot of variability. Some people drain, some people not drain, some people continue the fever. But our audience saying that they should drain the collection. 2nd week, 3rd week, drain the collection. So let us see what I'm going to see. What is the indication of drainage? So when you're a patient, so now after getting 1st week, 2nd week, do whatever best we did, but you can see the patient still in the severe necrosis, antibiotic, fluid, enteral nutrition, we have avoided whatever thing. But what is the indication of drainage? If a patient having a clinical suspicion or a patient having an infected necrotizing pancreatitis, preferably after 4 weeks, but not necessarily, as Dr. Gaurav said. Sterile, if the patient having a sterile necrotizing pancreatitis, later in the course, the patient having an ongoing gastric outlet obstruction, intestinal obstruction, biliary obstruction because of mass effect or a persistent symptoms, that becomes another indications of draining of the patient. I think we should really concentrate on the first. Yes, draining is the much, but I always worry about modality of drainage because it is the most important. Now, after 3rd week, after continuing conservative line of management, I was concerned that the wall is not matured. I should wait for the patient. Organ failure nahi hai. Fever is also only the concern that I was owing to 3. I was providing a very good calorie nutrition, almost 90 gram of protein, 24 to 100. He was tolerating the feed. So I thought, okay, let us continue for the patient. And that was the CT scan on week 3. You can see now the air is coming into the collections. Now that is we can't wait for here. The air was into the collection. That sees that if the patient having air into the collection without any intervention, that found that air forming bacteria is growing into the pancreatic necrosis. I am heading towards a very dreadful thing. The course will be more traumatic. You can see the collections in the paracolic gutter a little bit getting organized. The gastric wall collection almost 90%. The gastric wall is getting formed out here. And now the best state of management. Yes. What is the best management that I can able to drain? Can you guess a poll here? And I can also ask Saurabh Patel sir, can you, what is you, how you take it from here by the time the poll comes?
I think at this stage, endoscopic step-up approach is the best one to do, because since 2016, when we got the Panther trial, which has clearly stated that surgery comes actually the last mode of preference when we have to drain the collection. Endoscopic drainage followed by a direct endoscopic necrosectomy, that is step-up approach, is the best in terms of hospital stay, mortality, and overall outcomes of the patient.
Great. Very great. So your audience are fantastic. They are also think that yes, surgery is not an option for this patient. Traditionally from 2010, I think so, 2010 Panther trial, the traditional of approaching of pancreatic necrosis has dramatically changed. Surgery, no. So what are the options? What are the options here? Let the audience should know what we have are options among all the options what Saurabh has said. Yes, these are the various approach. The first picture is an open necrosectomy. Give the patient for open necrosectomy. Mortality 50% reported in the trial. If a patient having that patient of having everything. Second is a what type of technique? We can go a small incision, go inside, do necrosectomy, put nephroscope, remove all the debris. Third is like a pigtail. Yes, very nice pigtail, go nephroscope, go into the thing, manage properly. Fifth is the CT guided drainage, pigtail USG guided drainage, and then comes our more conservative type of approach or more very nice, minimally invasive techniques such as putting a stent into the collection, going through a stent, entering into necrosis. I'm going to say these are the various modality what we have. So what I am going to see, what Dr. Saurabh Patle has said, it's a Pantral trial, NEGM study, where the concept has completely evolved. They have randomized the patient into an open surgery and minimally invasive surgery. Minimally invasive surgery includes a ward and pigtail, and the open surgery is an open surgery. And what they have found in the right hand side, the mortality was higher in the surgical arm, the hospital stay, new onset organ failure was higher in. So that trial goes into that minimally invasive surgery is better than the open surgery. That we have learned in 2010 from NEGM paper. So now came, and we have learned from 2010 paper, our endoscopics are very much rare. If it is a minimal invasive, then tension trial has came in 2018. Where have they compared whether the endoscopic minimally invasive or a surgical minimally invasive techniques are better or not? And what they have endoscopic arm, they have done a endoscopic ultrasound guided plastic stent placement followed by necrosectomy, and in surgical group, they have put first a drain and then do some type of open or some type of what type of technique, and then they reduce the result, produce the result. And what they have found, that the major complication rate was similar in both the arms. So it is not like a superiority, like a surgery is superior to an endoscopic technique, but it is an endoscopy is always going good work for as compared to the surgery. And what is concluded, that endoscopic step of approach is not superior to surgical step of approach, but the rate of adverse event like pancreatic fistulas was higher in surgical arm. So yes, both are doing very well, but the rate of pancreatic fistulas was found to be more higher in the surgical minimally invasive type of technique. And one good guy in US, Shyam Vardalaju, has came and he's really compared a MISA trial where he compared a endoscopic minimally invasive versus a surgically minimally invasive technique, and he went to give a randomized control trial and that trial concluded that endoscopic step up technique is doing better than minimally invasive technique. Not only equal, it is going better in the term of hospital stay, in terms of pancreatic fistulas, in terms of new onset organ failure. Yes, because the tension trial was putting a plastic stent, Vardalaju group putting a metal stent and lamps and doing a necrosectomy. That's why the result was doing a much more better in an endoscopic treatment as kind of minimally invasive technique. So coming back, as Dr. Saurabh Patle say, we did yes, this is a very nice technique of endoscopic ultrasound in the hospital. We just put a scope inside the stomach. Within 10 minutes, we can really finish off this technique, and the patient with just a profile anesthesia, and we can just put a lamps. As you can see, the lamps getting deployed into the collection, and we can see a large amount of pus is pouring from stomach. Simultaneously, as Dr. Gaurav Padia said, we can put a PCD, 2 on the left side, 1 on the right side. It is more an hybrid type of technique we entered. We use a minimally invasive form from surgery. We are using an endoscopic form of technique of surgery, slowly upsizing the technique. But whether this patient relieved from that, and this is a CT image post cystogastrostomy, post pigtail, you are still seeing a large amount of collection. Patient is still running in high grade fever. So minimally invasive techniques we are using both technique. We can show the fever. Look at the fever chart. This is into third into 3. Patient is hospitalized, initially 10 days into ICU, 20 days in the hospital. The patient is running in high grade fever. And now I ask the question to the poll and also to Dr. Ravi Daswani. What do you think, what is the next best option? Should we go into a surgical form now? Or are we done? Or we do some sort of a necrosectomy, what we do?
So as we have chosen the endoscopic and also the percutaneous route, and we are trying to has higher morbidity and mortality. So in this context, the best option here would be direct necrosectomy by the endoscopic route as well as the percutaneous route. But one thing which we often see and miss out in patients who are running such grade of fever is simple pathologies like thrombophlebitis, which causes fever.
So you want to get some other causes also.
And yes, and cultures, probably fever is running every week, culture is also helpful. And another thing, as the CT showed, there is significant decrease in the size, and that is what most of the patients actually do not require necrosectomy. That is the point I would like to highlight here.
Yeah, yeah. Very nice, Ravi. So what is then, but our patient was not doing as what Ravi said. We have ruled out all the other causes of fever. The culture sensitive antibiotics were given, but what we did, the patient having a necrosis still there out there. The lesser collection are getting over. So what we have, now we have technique. Through the same lamps what we put, a metal stand, allow us to go through the lamps and enter into the cavity and remove all the solid material also. That is called as a direct endoscopic necrosectomy. And now we have also another technique, what the pigtail what we have put by a surgeon, we can also put a metal stand there and to enter into the cavity which is not approached by an endoscopic technique and perform a procedure called as a percutaneous endoscopic necrosectomy. And we did the same. As you can see, from the right hand side, I put a lamps into the percutaneous way where a large amount of pus is there, and from the endoscope I enter into the cavity and all the solid material which was seen was completely or mostly able to remove. This required, it's a tiring procedure, but yes, it is a minimally invasive technique what we are using just to make sure that we are pulling the patient and the cavity gets thrown. So we did almost 3 sessions of direct endoscopic necrosectomy and 2 sessions of percutaneous endoscopic necrosectomy, and what we have found, this is the result. The patient fever getting down in 4th week. Patient nutrition has improved, the cavity is getting collapsed. Yes, and this is the results we are producing. I am not telling surgery is not in the card, but I am propagating, yes, if we can pull the patient, if the patient faith is in with us, and we have a good amount of data to support that endoscopic minimally invasive techniques are better, doing less. These techniques gives that result. I can understand the patient can go here and there at any moment of a time. Surgeon is always on our loop card that okay, if you required help, it is a multidisciplinary approach. In Midhouse Hospital, surgeons, intervention radiologists, our radiologists, endoscopists are come together when such patients come into a patient. We discuss the patient with the various things, and now this is the thing. So our patient gradually improved, doing well, and in summary, for all of you ladies and gentlemen, DSAP scores are practical very severity score. It predicts a very good severity at 24 hours, though Mayo score, Apache scores are there, but they are the more lengthier scores. Ringer lactate is a preferred IV fluid, no doubt in it. Normal saline, no. I think ringer lactate. Goal-directed therapy, no role of prophylactic antibiotic unless proven. Early oral feeding as tolerated rather than keeping the patient per orally. It is always an enteral feeding. Don't worry about nasojejunal tube. You can put a Ryle's tube. Start the patient if the patient can tolerate the food. Not all the pancreatic collection need drainage. But preferred route of is always an endoscopic route in the first management. Endoscopic route. Open surgery not indicated. Wait till all the collection matured. But it's not like a compulsory. The patient is in sepsis. Don't have to wait for 4 weeks because it will go into higher mortality. Either we have to do something, and it is always an endoscopic technique, a percutaneous approach. Step-up approach has been a game changer, completely game changer from last decade. From last how many years I have not seen a single patient going into an open necrosectomy in my hospital. Surgical requirement using a step-up approach is only required this is a surgical in 10 to 20% of the patient if you have a good pancreatic surgeon at your hand. Thank you. It's my honor to invite all the people. This is the fantastic liver meet we're going to organize. It will be a much more larger scale, all international faculty going to come us, and we will be having a nice time academic session in coming January 2025. Thank you, all of you.
Excellent talk, Dr. Bhushan. I had one question. If we see such a large amount of air, so obviously apart from air forming organisms, one suspicion which comes into the mind is the possibility of cystocolonic fistula, that the colonic valve has fistulized and because of that the air is coming. So how does your management changes in these scenarios?
Gaurav. When a patient is sepsis, air forming bacilli without taking, the first thing comes into is a colonic fistula. When we do a CT scan, we request our radiologist to push a contrast and just make sure whether there is a colonic fistula. You are very correct. That's very important. Gaurav has highlighted. If the patient on upfront diagnosed as a colopancreatic fistula, that becomes a again another indication that this patient may go for surgery. Yeah.
Surgeons should be, we would think to involve surgeons in these scenarios.
Absolutely. And this is the collect. This I'm not telling that. I'm not at all telling that surgeon has no role in. They have an appropriate role when the patient comes into LNM. If the patient having a fistula site of thing, definitely then becomes a surgical indication to her. But still surgery, it will be a more conservative. Put a pigtail, go slowly, manage the patient in the not like a just open at the abdomen and just do whatever best we can. Otherwise, mortality is 50%. What is traditional mortality? Yes.
House is open for questions.
I think there are physicians, those who are managing pancreatitis in the first few hours, and the important point is fluid resuscitation. I mean, because when the patient goes, it goes to the physician or the surgeon. So the first 72 hours is the golden period when there is a lot of interstitial fluid accumulation, as a result of which, if you want to prevent that the patient should not go into necrotizing pancreatitis, adequate fluid should be resuscitated, and that should be ringer, and this point should be taken home. That's very important. And another thing is what we've seen in practice, because of the pain, they receive diclofenac, and the patient comes with renal failure, because all these patients are in underhydrated state. And when they receive analgesics like diclofenac, they tend to have renal failure. So that should be, as far as possible, avoided. Third thing is doing CT immediately within 24 to 48 hours. When the diagnosis is in doubt, then it is okay. But when the diagnosis, you have symptoms, you have raised lipids, there is no need of getting the CT in the first 72 hours. These are 2 or 3 observations of the practice which needs to be stressed.
Rightly said, sir. Very rightly said.
Excellent case, Dr. Bhushan, and I think it was very well managed. Few things, I mean, patient tolerating being in the hospital for such a long time is also difficult sometimes, but yeah, well managed in that case. I wish to point out one thing. What we routinely see is once the patient comes from periphery to a tertiary care center like Midas, most of them will receive higher antibiotics in the first and second week only. And by the time the patient reaches to a specialist, it's predominantly the game is about the MDR resistant like bacteria. So how do you tackle that in your practice?
What we can do, Ravi, is that if the patient, you said it's 10th week already on imipenem type of antibiotic, throwing imipenem, throwing fever and sepsis, is our rationale is to continue imipenem in that fashion only. Get a blood culture, get a procalcitonin, get another causes of fever, get a cultures out, and we can change a sensitive. But at that juncture of time, that one question you will always, one thing is like, can you step down the treatment? Your question might not, stepping is not, continuing is an easier option. Can you step down the antibiotic if there is no sort of fever? Yes, sir, we can do it. If your patient having a procalcitonin low, you are having a fever, there is no signs of infection you are able to see, we can really step down. A good decision, we can really take that decision in our broad shoulder, continue for something, look for any source of sepsin, and there only we can step up the treatment. That is, I think, in a practical way, I can answer the question. Yes, sir.
Second week,
yes, sir,
or third week, when is the most difficult time?
Yes, sir.
When you have an ill-defined collection,
Yes, sir.
are there any points to suggest whether a CT-guided percutaneous drainage is better, or you consider doing a US-guided drainage?
Sir,
So is there any
yes, sir.
guideline as to
Very-
how much
very-
wall
I
should be
didn't- in a
formed?
due
and all
respect
that?
of time, I didn't show that city of randomized control trial from Dutch people, and also, if I'm getting right, from John Hopkins people. They are doing an early drainage through endoscopic cystogastrostomy lens placement. Given a consent, just watch over the gastric wall. If the collection's gastric wall is formed by at least by 30-40%, don't worry about the 40-50% wall which has not been found. They have very safe and less adverse effect by doing a US cystogastrostomy. Given a concern, as you say, the wall is just ill-defined, the patient is definitely become an indication, the patient is throwing sepsis, you are having bacteria grow in your thing, you can't wait for much more time. US guided cystogastrostomy has found to be a place where they found a safely we can place, and we have placed it couple of times my way. One patient went bad, retroperitoneum, the collection went into retroperitoneum, I can enter into retroperitoneum, very hazardous, but yes, it has been tried. But if you go into more well, put a pigtail, sir. Put a pigtail, upsize the pigtail, wait for, don't worry for cystogastrostomy at very upfront. If you're having a very trained endocrinologist who are doing a good, definitely. We have done, I can see Saurabh sir doing very fantastic, one very incomplete wall was formed, but we've taken that risk and the patient come out that way. But given a stance, the center is not very equipped, definitely putting a pigtail is a better option, sir. I think so, that I can say. Yes, no, sir. Necrosis. Yes. We can drain some amount, wait, drain some amount, continue antibiotic, some infection can go out. If you are going like third day, fourth day, the drain is not coming up, it is a hard drain, upsize the drain, do CT scan whether the wall is getting formed or not. Unless you are doing that one step up approach, minimal step up. Go to surgeon if you are not having into concern. PCD, upsize, antibiotic, surgeon, minimally invasive. Ward technique. That is the only thing that we can say. Open, just don't burn your hand. The surgeon can. US versus CT guided drainage of PCD, any collections.
Second to third week collection with significant necrosis and minimal fluid.
Yes, no, so that's what I'm saying. We can do cystogastrostomy, US cystogastrostomy in second to third week of an ill-defined collection, given at least a gastric wall is formed. If gastric wall is not formed, you are saying it is not at all an ill-defined collection. It is better, you can't put a cystogastrostomy into peritoneum, which is ill-defined collection. That is all.
So I think what I will answer your question, that if the necrotic collection is near the stomach and easily approachable through the stomach, then we should prefer that, because putting lamps and necrosectomy sessions can be done serially. We have done percutaneous drainage with the catheter, enlarged the tract and putting the metal stent, and the necrosectomy can be done from there also. So the message which Bhushan wants to convey is that it should be as far as possible minimally invasive rather than surgically. But of course, some of the cases one should not be dragging towards minimally invasive and maybe necrosectomy. But 90% of the cases are being managed endoscopically or by percutaneous minimally invasive methods.
Thank you, sir. Thank you for your wonderful presentation. With this, we conclude this session. I request our speaker, Dr. Bhushan, sir, and our chairpersons to kindly collect the memento.